Welcome to our informational series on labor induction for Brigham and Women's Hospital. This series of videos is presented from the Induction Task Force Committee, which is a multidisciplinary group whose goal is to educate about the induction process at our institution with current and best practice guidelines. As always, an individual patient must use these videos as general education and consult with their provider about their specific needs. As medicine changes over time, these videos represent our current policies as of January 2023 and will be updated as needed.
The decision for induction is different for everyone. Once the clinical decision to book an induction is made with your provider, the office must arrange a hospital appointment. Many people will labor before they have to be induced, so inductions are only scheduled 7 days in advance. One of the exciting things about birth is that it cannot be reliably predicted, and this also pertains to the induction schedule. Many variables are considered for the inpatient labor appointment. For example, the patient's individual medical needs, the pediatric NICU, and the staffing and provider availability. The date and approximate time are booked with the central scheduling system at Brigham and Women's Hospital and are assigned with a standardized medical needs assessment submitted by your provider. The appointments will show up in your patient gateway as a time. However, these are just placeholders. The exact time that you are asked to come in will depend on the labor floor. Each day of the week has a varying number of slots that are available, but natural labor patients and floor census, or the number of patients in rooms, makes it impossible to predict exactly the chosen day and time can be accommodated. Most people will be called to come in for the afternoon or evening. But if the floor is quiet, you may be asked to come in earlier. Commonly, if there is high hospital volume, the provider will be notified if there is a delay or cancellation. While we know this causes disappointment, the ability for the team to care for all your needs comes first. For this reason, you must await a call from the labor and delivery floor to be told to check in at the registration desk. You cannot arrive prior to this call. Know that the common goal is a healthy mother and baby, and if spontaneous labor happens, we are excited to welcome our laboring patients at any time. As always, your provider who knows you best will be prepared to advocate for your situation. We often refer to labor scheduling like the weather, but before the advent of forecasting. We don't always know what might happen, but we're always prepared.
Who and what to bring? The decision for labor support is different for everyone. While we do have hospital policies, we recognize that all situations are not the same. Currently, at the time of this video, the policy of the hospital allows 2 support persons. Many things may cause this to change, and it's always important to check with your provider for any new updates. Visitors are not allowed on labor and delivery, which is a locked unit for the protection of our patients. We recommend that all family members who are not direct support persons remain at home, as there's no waiting area for visitors. Once you're on the postpartum floor, visiting hours are between 1 and 8 p.m. While this is an exciting time you want to share, remember that birth is not a spectator sport, and only those persons who are truly supportive should be part of your labor team. You should let your provider know if you have any questions or extenuating circumstances. We want your team to be the most important people that help you with the labor process and recovery.
Some people prefer to bring items to the hospital for their comfort, although we supply almost everything you might need. You do need to provide an approved car seat to take baby home, but you can collect this once you have gone to your postpartum floor and do not need to bring it to labor and delivery. That said, there are many items you might not want to forget. Cell phone chargers with long cords, as the outlets can be far from reach, comfortable clothing, toiletries, eye masks, and earplugs for sleeping if desired. Pillows and blankets are provided, but again, you may prefer your own. Breast pumps are in all rooms, but you may want a boppy pillow for comfort if breastfeeding. You do not need to bring birthing balls, stools, or squat bars, as those are all provided. Support persons may want warm clothing, as the labor rooms are often cooler for your comfort. You have access to room service in the cafeteria, but some people bring a small cooler or snacks. In the postpartum rooms, there is a small refrigerator, but not on labor and delivery.
What happens on admission? The admission process is the same for all patients. You'll stop in the registration area and receive a hospital bracelet that you must not remove while you're in the hospital. Support person or persons will also be given a bracelet. The nursing staff will bring you into a private space without your support person for a brief review. If you're being admitted to a labor room directly, your support team will be brought in once the admission questions are completed. However, if you're being admitted into the triage area, you're only allowed one support person due to the confines of this small space. Your labor team will include the labor and delivery staff, as well as your own support members, and we will review the plan for your admission together. Many people have had changes in their health, their cervical exam, or desires since they were last seen in the office, which requires a reevaluation before a final plan can be formed. Prior office discussions are meant to be flexible, and solutions may need creativity. We refer to this as a game day decision. What may have been decided prior might need some tweaking, and your healthcare team will make certain that all questions and information you need to understand this process are reviewed. You'll have the opportunity to express your preferences, which may have also changed, and know that we are all equal members of a team, respecting each other. We will jointly place your information on your team birth board and adjust it as the labor progresses. At Brigham and Women's Hospital, we want you to feel connected to the staff caring for you and comfortable asking questions to understand the process of birth. We expect that no two births are the same, and our goal is a unique and personal experience with healthy outcomes for you and your baby. Modern medicine, for all the advances that have been made, still does not completely understand what triggers the process of labor in humans. Many people are aware of different natural techniques to induce labor, and there are many things that your provider can review with you prior to booking an induction. Your cervix is given a score. We call this the Bishop score. This tells us things about your cervix, including how dilated it is, how thinned out or effaced it is, how soft it is, as well as the position of the cervix within the vagina, if it tips back or to the front, and also the station of the baby, how high or low the head is. All of this, along with your specific situation and desires, matters when deciding on the correct intervention. We do try to practice evidence-based medicine, but we also want you to feel you can trust your body. In general, your cervical exam will determine if you need what we call cervical ripening. Sometimes your cervix is ready for labor already, and you can skip this part. Often, especially for first-time births, the cervix needs a little help getting ready for labor. We call this cervical ripening. It's often the longest and least predictable part of the process. Some offices can perform cervical ripening as an outpatient, meaning that you can either have it done in the office or in the triage area of the hospital, not in a labor room. This is more like a visit rather than the admission, and it's scheduled separately from the inpatient induction appointment. This allows you to leave after a period of monitoring to your home. For most people, it's safe and preferable to be outside of the hospital during the early part of labor. At times, this can take several days, allowing the body to naturally respond to each intervention to see if spontaneous labor starts. Some patients may not be able to have outpatient ripening, and the cervical ripening needs to be done in the hospital at the same time as the induction. This means the patient's not able to leave, but you can still move about. Cervical ripening is generally divided into mechanical and medical options. Mechanical options are devices that can be placed into the opening of your cervix to apply pressure to the cervix. It might include a balloon device attached to a flexible tube to allow water to be inserted to inflate it. So let's see. Well, that's kind of how much it inflates. This can remain in place either until it falls out like a small tampon, your water breaks, or the provider removes it within 6 to 12 hours. If you have a balloon as an outpatient, sometimes you can remove it yourself by cutting it and allowing the water to flow out, and it'll gently slip out. Other options for mechanical stretching include a dilator type of device which absorbs water like a tampon and slowly expands. These look like small skinny tubes about the width of a pencil, but once in place they expand to many times their size. Usually several are placed into the cervical canal by your provider with a speculum like a pap smear. These are left in place until the provider removes them, usually within 12 to 24 hours or if your water breaks. If they fall out at home, we recommend placing them in a small baggie so that we can count them when you arrive at the hospital. Medical options for cervical ripening involve prostaglandins, which are naturally found in the uterus and play a role in labor. There are several biochemical or man-made options, but the goal is the same: to soften your cervix and try to stimulate natural contractions. They can be given as a pill by mouth or placed in your vagina, but all do require monitoring for a designated period of time. And then they can be repeated several times over the course of the ripening process over several days. If you're having cervical ripening in the outpatient setting, we only allow one type of intervention at a time. However, for those having ripening in the hospital, studies have shown that combining interventions is the best approach. So if you're in the hospital and need ripening, we prefer to do both a mechanical option combined with a medication.
Once the cervix is ready for labor, we have two main options to move things along: Pitocin and breaking the water. They are both very safe and effective methods to simulate labor. Pitocin is a synthetic form of the natural hormone oxytocin that the brain makes during the labor process. This medication causes the uterus to contract, which in turn may cause the body to make its own natural oxytocin as well. It is given through an intravenous tube and tightly regulated. The dose is adjusted slowly over several hours and can be reduced or discontinued if the natural labor progresses. We monitor how your uterus and your baby respond to the medication and adjust or remove it if there are any concerns. Fortunately, Pitocin clears the bloodstream in a matter of minutes, so if we no longer want to use this, we can just stop the IV. Breaking the water, or artificial rupture of membranes, is really a common and fairly natural way to stimulate labor. Breaking of the water is done with a plastic device, much like a crochet hook, that has a smooth surface with an internal protected area that can scratch a tiny hole to release the fluid. For safety, this can only be done at the hospital once admitted to a full labor room. Breaking the water helps in several ways. First, the amniotic fluid contains many natural prostaglandins, which help to continue to ripen the cervix and promote labor. Second, breaking the water allows the baby's head to come down and put more pressure on the cervix, which also helps to stimulate the labor. As always, your provider team will monitor your progress and update the plan. Know that all changes should be something that everyone is aware of and agrees to. If you have any questions, we welcome them. We see thousands of births, and this may be your first one, so we have lots of advice and knowledge to help you through the process.
Common concerns and myths of labor are addressed in this section.
First myth: if I have an induction, it will make me have a cesarean delivery.
Many studies have been done about this topic and have found that for most people, this is not true. Inductions can take longer than spontaneous labor, but as long as everyone is patient, inductions don't increase the risk for a cesarean delivery. At the Brigham, we're always patient, and provided both mom and baby are doing well, vaginal delivery is our goal. Second myth: I won't be able to have a natural birth without an epidural if I have an induction.
False. A person's pain management is a choice, and all options are available to support labor. Certain medications require continuous monitoring, and thus some options, like the tub or the shower, are not permitted, but remote monitoring can help you move around. Medication and regional anesthesia, such as an epidural, are always an option for those who desire it. Some inductions take longer than a spontaneous labor, or come on quicker than a spontaneous labor. Adjusting expectations to know that contractions and the coping skills needed to get through them are personal. People who choose unmedicated birth can do this successfully with an induction of labor. As always, a discussion about your preferences will be supported, and if things change, we will all help you with your choices. Third myth: medications will hurt my baby or make it impossible to breastfeed.
Just know, medications are given that we provide are safe, regulated, and studied. All induction medications permit breastfeeding, and truly, milk production is related to the removal of the placenta, which triggers the process of hormonal changes. Induction medications do not change that process. There are no medications that are used for induction of labor that are unsafe for your baby. And fourth myth: induction is bad for the baby because the baby's not ready to come.
False. When a medical condition arises, delivery can in fact be safer for the baby. In some pregnancies, we must weigh the risks of keeping the baby inside with the risks of being born early. For this reason, no elective or non-medical induction or C-section should be done but before 39 weeks. This timing is safe for both mothers and babies. On occasion, a baby born after induction will need more monitoring or admission to the neonatal intensive care unit. But this is true after spontaneous labor as well. Fifth myth: breaking my water will cause me to have an infection or a cesarean delivery.
False. Many people are concerned about the safety of breaking their water in labor. It is true that once the water is broken, the chance of infection is higher. However, breaking the water also makes labor go faster, and the chance of infection is lower because of the shorter time in labor. Studies have not shown that breaking the water is associated with higher rate of infection or a cesarean, but it has shown it's a safe way to stimulate labor, and it's associated with a shorter time on labor and delivery, which people generally prefer. But remember, every situation is unique, and we encourage you to talk with your team about what feels best for you and your baby. As always, Brigham and Women's Hospital wants to make certain that everyone feels they're an equal and valued member of the team. We hope to create for you a safe, special, and healthy experience.